47% of American adults. 47%. That is the proportion of American adults currently living with hypertension, elevated blood pressure, according to the most recent data from the Centers for Disease Control. Nearly half the adult population, and in adults over 60, the number rises above 70%, more than 7 in 10. Of those, roughly half have their blood pressure adequately controlled. The other half do not, either because they are undiagnosed, because their medication regimen is not optimized, or because the dietary and lifestyle factors driving their blood pressure upward are not being systematically addressed alongside the pharmaceutical management. Here is what most people do not hear clearly enough. Blood pressure is not a binary condition, medicated or unmedicated, controlled or uncontrolled. It is a continuous physiological variable that responds to an accumulation of inputs. The food that enters the body every morning, the fluid consumed throughout the day, the weight carried in the abdominal region, the inflammatory burden of the diet, the quality of the sleep, the function of the kidneys. Every one of those inputs shifts blood pressure either upward or downward continuously across every 24-hour period. Medication acts on some of those inputs pharmacologically. Diet acts on some of them nutritionally. They are not alternatives to each other. They are parallel interventions operating through different mechanisms on the same biological target. The strongest evidence-based approach to blood pressure management in adults over 60 combines both and understands how each works. Today, I want to tell you about the single breakfast food with the most consistent, best documented, and most mechanistically well understood blood pressure lowering effect of any food studied specifically in the morning consumption context. That breakfast food is common oats. Not a supplement, not a specialized product, not something requiring a health food store or a prescription. Oats, the grain, cooked as porridge, prepared overnight as soaked oats, consumed in the first meal of the day, daily. I'm going to tell you exactly why they work. And it is not what most people assume. Most people, when they hear that oats are good for cardiovascular health, think of cholesterol. The connection between oats and LDL cholesterol reduction is the most widely communicated piece of oat nutrition science. The FDA authorized a health claim for oat products and heart disease risk in 1997, specifically based on the LDL lowering effect of oat beta-glucan. That claim is legitimate, and the evidence behind it is strong. But cholesterol reduction is not the primary mechanism through which oats lower blood pressure. And the blood pressure story is more interesting, more direct, and more relevant to the immediate physiology of what happens inside the cardiovascular system when oats are consumed daily than the cholesterol story, which operates over a longer biological timeline. There are 3 distinct mechanisms. Each is separately documented. Each is clinically meaningful. Together, they explain why oats specifically, not simply fiber, not simply whole grains, but oats with their specific nutritional fingerprint, produce the blood pressure reductions that the clinical evidence has consistently documented. Mechanism 1, beta-glucan and the gut vascular axis. Oats contain a type of soluble dietary fiber called beta-glucan that is present in particularly high concentrations compared to other grains. Beta-glucan is not absorbed in the small intestine. It reaches the large intestine largely intact, where it serves as a fermentation substrate for specific bacterial populations. The same microbiome mechanism I described in the context of resistant starch, but through a different fiber structure and a partially different set of bacterial targets. The fermentation of beta-glucan produces short-chain fatty acids, primarily propionate and butyrate. Propionate has a direct effect on the renin-angiotensin-aldosterone system, the RAS, the primary hormonal pathway through which the kidneys regulate blood pressure. Propionate activates free fatty acid receptors on cells that regulate renin secretion in the kidney, suppressing renin release and thereby reducing the downstream production of angiotensin II, the potent vasoconstrictor that is the primary target of ACE inhibitors and ARBs, 2 of the most widely prescribed antihypertensive drug classes. This is the same molecular target, the same renin-angiotensin system, through a different mechanism, nutritional rather than pharmacological, but converging on the same rate-limiting step in the blood pressure regulation pathway. A 2021 study published in the journal Cell Host and Microbe, examining the relationship between gut microbiome metabolites and blood pressure in a large cohort, found that circulating propionate levels were inversely associated with blood pressure in a dose-dependent manner. The higher the propionate, the lower the blood pressure, with the association holding after adjustment for confounding variables including age, BMI, medication use, and sodium intake. The study identified short-chain fatty acid production from dietary fiber fermentation as one of the most mechanistically coherent explanations for the blood pressure differences observed between high and low dietary fiber consumers. The gut vascular axis, the pathway through which what happens in your intestinal microbiome influences the function of your blood vessels, is one of the most active areas of cardiovascular research in the current literature. Oat beta-glucan is among the best characterized dietary fibers for specifically driving the propionate RAS pathway within this axis. Mechanism 2. Avenanthramides and nitric oxide. This is the mechanism that most people have never heard of, and it is the one that most directly and most acutely affects the physiology of blood pressure in the hours following a bowl of oats. Avenanthramides are phenolic compounds found almost exclusively in oats. They are not present in other common grains at meaningful concentrations. They are produced by the oat plant as part of its defense response against fungal infection, and they are concentrated in the outer bran layer of the oat grain. Their cardiovascular significance was not well characterized until the past 2 decades, and the full scope of their effects is still being actively investigated. The most important documented effect of avenanthramides relevant to blood pressure is their stimulation of endothelial nitric oxide synthase, eNOS, the enzyme in the cells lining blood vessel walls that produces nitric oxide. Nitric oxide causes relaxation of the smooth muscle cells in the arterial wall, reducing vascular tone and consequently reducing peripheral vascular resistance. Since blood pressure is the product of cardiac output and peripheral vascular resistance, reducing peripheral resistance directly lowers blood pressure. Avenanthramides drive the production side of the nitric oxide pathway. PDE inhibitors drive the degradation side. The net result of both, more nitric oxide available to relax arterial smooth muscle, is the same. Avenanthramides drive the production side of the nitric oxide pathway. PDE inhibitors drive the degradation side. The net result of both, more nitric oxide available to relax arterial smooth muscle, is the same. A 2014 study published in the journal Nutrition and Metabolism administered an avenanthamide-enriched oat extract to adults with hypertension and measured blood pressure, flow-mediated dilation, and plasma nitric oxide metabolite levels at baseline and after supplementation. The avenanthamide group showed significant increases in flow-mediated dilation, the gold standard non-invasive measure of endothelial nitric oxide function, and significant reductions in blood pressure compared to placebo. The researchers identified eNOS stimulation as the primary mechanism, consistent with the in vitro and animal data demonstrating avenanthamide's effects on eNOS expression and activity. Flow-mediated dilation improving means the endothelium is producing more nitric oxide and the arterial wall is responding more effectively to the vasodilatory signal. This is not a peripheral marker of health. It is a direct measure of the biological process that determines whether arteries relax appropriately under hemodynamic load and whether blood pressure is regulated efficiently at the vascular level or driven upward by stiff, poorly responsive arterial walls. The avenanthamide story is important for a specific practical reason. It means that the blood pressure benefit of oats is not simply a beta-glucan story that could be replicated by any soluble fiber supplement. It is a story about the specific phytochemistry of oats, compounds present in oats and not in psyllium, not in pectin, not in generic fiber supplements. Eating oats specifically, rather than supplementing generically with fiber, captures this mechanism in a way that no fiber supplement replicates. Mechanism 3. Magnesium, potassium, and direct electrolyte effects. A serving of cooked oats, 1 cup, prepared from approximately half a cup of dry rolled oats, provides approximately 57 milligrams of magnesium and 164 milligrams of potassium. Neither of these is an enormous quantity relative to daily requirements, but in the context of a population in which both nutrients are widely deficient, with an estimated 50 to 60% of American adults consuming below the recommended intake for magnesium and the majority consuming below the adequate intake for potassium. I described the potassium blood pressure mechanism in detail in the banana video. The renal sodium excretion pathway through which adequate potassium intake drives blood pressure downward is well documented and operates additively with the RAS modulation from propionate and the nitric oxide stimulation from avenanthramides. Magnesium is a calcium channel antagonist. It competes with calcium for entry into vascular smooth muscle cells through voltage-gated calcium channels. Calcium entry into smooth muscle is the trigger for contraction, vasoconstriction. When magnesium occupies these channels at adequate intracellular concentrations, it reduces the calcium-mediated vasoconstriction that contributes to elevated peripheral resistance. This is the mechanism by which intravenous magnesium is used clinically in acute hypertensive emergencies. The same principle operates more modestly through dietary magnesium adequacy. A 2016 meta-analysis in the journal Hypertension, examining data from 34 randomized controlled trials of magnesium supplementation, found that magnesium supplementation produced statistically significant reductions in both systolic and diastolic blood pressure, with larger effects in studies where the supplemented population had lower baseline magnesium status. The dose-response relationship suggested that the benefit was greatest in restoring adequacy from deficiency, consistent with the principle that nutritional interventions produce the largest effects where the deficiency is greatest. The dose-response relationship suggested that the benefit was greatest in restoring adequacy from deficiency, consistent with the principle that nutritional interventions produce the largest effects where the deficiency is greatest. The 57 milligrams of magnesium per serving of oats consumed daily contributes approximately 14% of the recommended daily intake for older men and 18% for older women. Combined with other dietary sources of magnesium, dark leafy greens, nuts, seeds, legumes, it can meaningfully contribute to bridging the deficit that is present in the majority of this population. The clinical evidence, what the trials show. The mechanistic evidence I have described is not simply theoretical, it is corroborated by a consistent and replicated body of randomized controlled trial evidence that places oats among the best evidenced dietary interventions for blood pressure management in older adults. A 2014 meta-analysis published in the American Journal of Hypertension systematically reviewed 12 randomized controlled trials examining the effect of oat consumption on blood pressure across a combined participant population of over 1,000 adults. The pooled analysis found that oat consumption produced a statistically significant reduction in systolic blood pressure of approximately 2.7 mmHg and diastolic blood pressure of approximately 1.5 mmHg compared to control conditions. These numbers deserve context rather than dismissal. In population-level modeling of cardiovascular risk, a sustained 2 to 3 mmHg reduction in systolic blood pressure is associated with an approximately 5 to 8% reduction in stroke risk and a 3 to 5% reduction in coronary heart disease risk. These are not negligible reductions. At the population level, they translate to substantial reductions in cardiovascular events. For any individual, the effect may be larger or smaller depending on baseline blood pressure, dietary context, and the degree of deficiency in the specific mechanisms oats address. But the direction is consistent and the magnitude is clinically meaningful. A 2015 randomized controlled trial published in the American Journal of Clinical Nutrition specifically recruited participants with elevated blood pressure, above normal but below the threshold for pharmacological treatment, and randomized them to 12 weeks of daily oat consumption versus a refined cereal control. The oat group showed significantly greater reductions in systolic blood pressure than the control group, with the effect most pronounced in participants with the highest baseline blood pressure, consistent with the principle that the intervention addresses a specific physiological deficit most effectively, where that deficit is most significant. How to use this correctly? Because the specifics matter considerably. The form of oats matters more than most nutrition discussions acknowledge. Steel-cut oats, produced by cutting the whole oat groat into pieces with steel blades, retain the most intact structure, require the longest cooking time, and have the lowest glycemic index of all oat preparations. The physical integrity of the grain means that digestive enzymes encounter more resistance in breaking down the starch, producing a slower and more modest glucose response. They also retain the highest concentration of avenanthramides because the minimal processing preserves more of the outer bran layers where these compounds are concentrated. Rolled oats, the standard supermarket variety, produced by steaming and flattening the oat groat, retain most of the beta-glucan content and a significant proportion of the avenanthramides. They are a practical and nutritionally sound choice for daily use, with a cooking time of 5 minutes that makes them realistically compatible with morning routines. The glycemic index is higher than steel-cut oats, but substantially lower than instant oats. Instant oats, pre-cooked, finely processed, and typically flavored with added sugar, sacrifice the most nutritional integrity of the three preparations. The processing substantially degrades the beta-glucan structure, the viscous gel that beta-glucan forms in the gut, which is the physical form responsible for its fermentation benefits and its cholesterol-lowering effects, is disrupted by the fine grinding and pre-cooking. The added sugar and flavored instant oat packets introduces the same insulin-spiking inflammatory response that undermines many of the benefits the oats themselves provide. The convenience premium of instant oats comes at a meaningful nutritional cost relative to rolled or steel-cut preparations. The practical recommendation is steel-cut oats prepared in advance. They can be cooked in large batches and refrigerated for 3 to 4 days, then reheated in 2 to 3 minutes, or rolled oats prepared fresh each morning. Both deliver the beta-glucan and avenanthromide content that the clinical evidence supports. Instant oats in plain form, without added sugar or flavoring, represent a reasonable compromise when time is genuinely limiting, though their viscous beta-glucan content is lower than the less processed alternatives. The additives you choose to include in your morning bowl matter significantly for the final blood pressure outcome. A plain bowl of rolled oats, cooked in water or unsweetened plant milk and topped with a tablespoon of ground flaxseed, a small handful of walnuts, and a half cup of fresh or frozen berries creates a breakfast that compounds the nitric oxide, RAS, and electrolyte mechanisms of the oats with the omega-3 content of the flaxseed, the antioxidant load of the berries, and the additional magnesium and potassium of both. The blood pressure effect of this combination is greater than oats alone, because each component operates through a mechanism that the others do not fully replicate. What undermines the effect? Brown sugar, flavored syrups, sweetened dried fruit, or any substantial added sugar introduced into the oatmeal preparation. These inputs drive the insulin response that counters the propionate RAS modulation, introduce the inflammatory signaling I described in the sugar script, and shift the metabolic environment in the hours following breakfast in the direction that increases rather than decreases vascular resistance. A bowl of oatmeal sweetened with 2 tablespoons of brown sugar delivers the beta-glucan and avenanthramides of the oats and the glycemic spike of a dessert simultaneously. The benefits are partially offset by the harms in the same meal. Honey in small amounts, a teaspoon rather than a tablespoon, or fresh fruit for sweetness keeps the glucose response modest while providing additional polyphenol and micronutrient content. Ripe banana slices mashed into the oatmeal add the potassium contribution I described in that video. Cinnamon, Ceylon cinnamon specifically, as I described in the coffee and heart health video, adds an additional layer of ENOS stimulation and insulin sensitivity support. The morning bowl of oatmeal is a platform, not a fixed recipe. What consistent daily consumption looks like over time. The RAS modulation through propionate requires the microbiome to establish the fermenting populations that produce propionate efficiently, a process that takes approximately 2 to 4 weeks of consistent daily fiber delivery to reach its full expression. The avenanthromide effect on eNOS has both acute and chronic components. A meal of oats produces an acute nitric oxide response, and daily exposure produces a cumulative upregulation of eNOS expression in the vascular endothelium that makes the response larger and more sustained over weeks of consistent intake. The clinical trials showing the significant blood pressure reductions ran for 8 to 12 weeks. The effects at 12 weeks were consistently larger than at 4 weeks in the studies that measured at multiple time points. Consistency across weeks and months is what the evidence was measuring, not the effect of a single bowl or even a week's worth of oats. The commitment required is one breakfast, every morning, prepared in a form that preserves the beta-glucan and avenanthromide content, consumed without the added sugars that undermine the mechanism. That is the entirety of the intervention. It is accessible, affordable, and requires a cooking time of 5 to 8 minutes in its most effective forms. The important qualification about medication. The title of today's video says without medication, and I want to address that framing carefully and directly. For adults whose blood pressure is in a range that a physician has determined requires pharmacological treatment, the evidence I have described today is not a reason to stop or reduce medication without physician guidance. The blood pressure reductions from oats, averaging 2 to 3 Mhz in the controlled trials, are meaningful as a population-level contribution to cardiovascular risk reduction, but are not of the magnitude that adequately substitutes for antihypertensive medication in people with significantly elevated blood pressure. What the evidence does support is that daily oat consumption, combined with other evidence-based dietary and lifestyle modifications, can produce cumulative blood pressure reductions that are clinically significant, and that in some people with borderline elevated blood pressure, sustained implementation of the dietary approach I have described may bring blood pressure into a range where medication initiation is deferred, or in people already on medication, may contribute to a level of control that allows dose reduction in consultation with their physician. The conversation about whether dietary management alone is sufficient for any individual is a clinical conversation, one that requires knowing that individuals' blood pressure measurements over time, their cardiovascular risk profile, their other health conditions, and their medication history. It is not a conversation that any general nutrition video can conduct on behalf of any specific person. What this video provides is the mechanism, the evidence, and the practical implementation. The clinical application of that information to your specific situation is the work of the physician who knows your numbers. If your morning currently begins with toast, cereal, yogurt, eggs, or anything other than oats, and your blood pressure is something you are managing or thinking about, You now have a specific, mechanistically grounded, clinically evidenced reason to consider whether the first meal of the day is doing the work it could be doing. One bowl, every morning, the same consistency that built the blood pressure problem applied in the direction of addressing it. That is the whole argument. If this gave you clarity about why oats specifically, not just fiber, not just whole grains, but oats with their specific avenanthromide and beta-glucan chemistry, produce the cardiovascular effects that the evidence documents, hit the like button right now. It tells this platform that specific mechanism-driven nutritional science for adults over 60 deserves a consistent and wide audience. Subscribe and turn on the notification bell. Every week there is one video here that does exactly this. Explains not just what to eat, but why the biology works the way it does, because that understanding is what makes the habit sustainable. Leave me a comment with this. What does your typical breakfast currently consist of? And have you noticed any relationship between what you eat in the morning and how you feel in terms of energy and blood pressure through the rest of the day? Write it below. I read every comment and I respond when I can.